there are a variety of factors, both with the individual that has OCD, and also in terms of accessing appropriate treatment that can make it take a bit of time to be able to get an appropriate diagnosis. Even now, my experience is with a new client, I'm no expert on them. I have experience with OCD, so it's really about me bringing what I know, them bringing what they know, and us being able to collaborate on something together. So first of all, anxiety in and of itself isn't a disorder. It's an emotional experience. A normal human emotional experience might not be very comfortable, but it's part of being human.
We would like to acknowledge the traditional owners of the land, the Wurundjeri and the Boon Wurrung people of the Kulin Nation, which is where this podcast is recorded. And we would like to pay our respects to their elders past, present and emerging.
Hi, I'm Penny Moody.
And I'm Angie Green. And we are the hosts of It's Not What You Think,
A podcast about the horrors and hilarities of living with OCD. That sound all right? Okay. Yeah. Claire, thank you so much for joining us today. Because this is one of the first episodes of the podcast, we wanted to talk to you about the process of getting an OCD diagnosis and a lot of things that surround that. But for a lot of people, getting the diagnosis isn't one of the first things that happens in an OCD journey. I know from personal experience there can be a huge gap between onset of symptoms and actually receiving a diagnosis.
Yeah, that's quite common.
Yeah. And for me it was about 23 years. I've read the average is about 9. I mean, in your experience, is this still the case? Is there still a big gap between those two things?
Yes. I mean, maybe not as much as 23 years. I think that's changing. I think with increased knowledge about OCD, people are understanding more and maybe presenting and asking for help earlier on. But there are a variety of factors, both with the individual that has OCD, and also in terms of accessing appropriate treatment that can make it take a bit of time to be able to get an appropriate diagnosis. So I'm not sure if you want me to go into, but for the individual, and I'm not sure what the experience is like for you, but often there is a lot of shame and embarrassment. So the nature of an obsession is that it's in complete contrast to your sense of self. But there's a part of you that fears that, hold on, maybe that reveals something about the truth of who I really am. And so because of that, there's a lot of anxiety about what does this mean about who I am? Can I really share this with someone else? Am I going to be judged for this? Am I a bad person?
Yeah.
So there's a real fear of disclosing that and fear of judgment. And sometimes there's fear for negative repercussions. If I was to share this to someone, am I going to lose access to my children? And am I going to lose my job, for instance?
Yeah.
my friends, my family,
Yeah.
my mind. Yeah.
Huge. So there's a lot sort of that make it uncomfortable for someone to even share it with anyone else, let alone a health professional.
Yeah, absolutely. And I think we'll definitely dive more into that in a bit, but maybe just taking it back to basics, Claire, when we're talking about a diagnosis, who generally does diagnose OCD and how do they do it?
So at this stage, there's no sort of biological markers or objective testing. So you can't get a blood test or a brain scan to be able to identify if someone has OCD.
It would feel so much easier.
That would be nice if you could sort
It'd be
that
nice
out.
if we could have that. But when it comes to mental illnesses in general, mental disorders in general, clinician interview is the main method which someone would be able to understand if someone meets criteria for a diagnosis. So this would be with a GP or a mental health professional, so a psychologist or psychiatrist or other mental health professionals. And the process is usually clinician interview, them asking lots of questions about your current experience, how often you've been having these symptoms, what these symptoms mean to you is one of the key questions I'm always trying to get a little bit of a feel for, not just the behaviour that they're doing, but the reasons behind the behaviour that they might be doing. And we're sort of assessing the information that people provide against, say, diagnostic criteria to see whether or not someone meets criteria for having OCD.
And do you find, Claire, because I'm someone who also lives with it, people know Penny and I both live with it, because it's so hard to describe or explain even to yourself because it is such a nuanced disorder, if you will. Do you find that people often get misdiagnosed?
It's not uncommon.
Yeah.
So I've certainly had clients. Now, I mean, I really work a lot with OCD. So by nature, by the time people are coming to see me, they feel like they have OCD.
Yes, right.
So it's a bit different compared to, maybe before I had as much experience in this area and I'm sort of a bit more blind into what's going on and what people are presenting with. I've certainly had lots of experiences where clients have previously had treatment with other professionals, and maybe it's been for anxiety, generalised anxiety disorder or trauma, and OCD hasn't really been mentioned. It hasn't been a target for treatment, hasn't been diagnosed. Now, sometimes that's because it's not the primary presenting issue at that time, so it's appropriate. Other times it's because it's hidden. It's hidden behind the symptoms of the other disorder, and so they might not be responding as well to treatment. People not, the client and the clinician might not really understand about what's going on. It just might not be targeted to the OCD. Does that make sense?
No, absolutely. And it's just, it's so hard for people, I imagine, because, therapy even within itself is so exhausting. Living with what we're living with is so exhausting, and, to go through the process of not getting the right treatment. Because Claire, I got diagnosed at 19. But before seeing Andrea Wallace, who's my psychologist now, I think 3 or 4 years ago, I was working with people who, on their website said that OCD is something that they work with. However, it was only until seeing Andrea that I actually learned the skills to combat OCD.
Yeah.
And so essentially for the first 2 decades of my life was doing talk therapy and types of therapy that didn't really work. So it's hard enough even when you have been diagnosed but you're not getting the right treatment.
Absolutely.
And let alone being misdiagnosed and not getting the right treatment or medication or whatever it might be. How
can people navigate this?
Yes.
This space?
Yes. And do you think this also comes to the medical profession not understanding OCD enough or to where it should be, or is that not the case?
No, I think it's changing. I think medical professionals, mental health professionals, our knowledge of OCD is increasing. And that can start with things like this, the sort of public knowledge and interest increases, and so clinicians start to sort of upskill themselves as well. There's no special qualification that someone can do to say they have experience in working with OCD.
Okay.
So if you go to a search engine, a psychologist search engine such as the APS Finder Psychology Service, and you search under OCD, you're going to come across people, clinicians, that have self-reported themselves as having an interest in OCD. Now, maybe that's because they do. Then that's certainly, I did that too. Maybe that's because it's an interest area that they're wanting to grow in. Maybe it's because they just want to get referrals and they want to get busier. For whatever reason, they've self-referred themselves as having an interest in that space. The other search engine which I've been recommending to clients is using OCD Bounce, which is ocd.org.au, and that is clinician-referred search engine. So that's where I was nominated by another clinician as someone that has experience in working with OCD.
Right.
So all the psychologists and psychiatrists and mental health professionals on that search engine have been acknowledged as having experience in working with OCD. Now, it's relatively new. If your clinician's not on there, I wouldn't worry. I was only on it last year, for instance. I didn't even know about it myself.
Yeah.
But it can sort of help you with trying to get a bit of a feel for which clinicians might have, experience in this area. I think we don't want to be too perfectionistic sometimes about finding just the right, in inverted commas, person. I think someone that you feel comfortable with, but that you can also learn and grow with, and they can upskill. Yeah. Like I was a baby psychologist at some stage, and I didn't have the experience that I have now with OCD, but I upskilled. I did reading, I did supervision. Me and the client worked together, and even now, my experience is with a new client, I'm no expert on them. You know, I have experience with OCD, so it's really about me bringing what I know, them bringing what they know, and us being able to collaborate on something together. So I think that's the sort of framework I'd be looking for in a psychologist or in a mental health professional, someone you can work with and learn more about what's going on for you together.
Is it important, do you think, Claire, for that clinician to have specific experience with like exposure and response prevention therapy?
Yes.
Yes, okay.
Yes, I would say while there are, so in terms of clinical guidelines, ERP or exposure and response prevention is the first line treatment, meaning if someone presents with OCD, this is the first treatment that is recommended to try. And so ERP is what I would be looking for in a therapist that works with OCD. There are other treatment modalities that are being researched, but they're not part of clinical guidelines, so there's not the same evidence base to their utility in working with OCD.
Right, okay. And, I mean, people very much have the right, don't they, to ask their clinician questions before kind of starting therapy. Yeah.
So one of my sort of emails, you know, if people contact me and say, I'm like, sorry, I'm unavailable, go to OCD Bounce, go here, go try out before you book an appointment, find out their experience with OCD. See if they say the words ERP.
Yeah.
If they don't say the words ERP, then they might not be using exposure and response prevention. So, you know, I know that I use those words because I know that that's something that's going to be important to that population group.
Yeah, I think that is super important. And an example recently was that a loved one recently got diagnosed with OCD, and it was up to them to find a clinician, what have you. And I was like, just making sure not saying the name, but I said, ask if they do X, Y, and Z, and they had no idea about what I was talking about and what have you. And I'm like, but these are the kind of things, these are the skill sets that this person should really have if they are working with OCD. So would you, Claire, recommend, is there a list, like a set of questions that you think, if someone thinks that they have OCD, what would be the type of questions that you, A, how do you approach a GP, and B, what are the kind of questions that you're asking a potential clinician?
So in terms of it with a GP, I might present to first of all, I would ask the reception team for a long appointment.
Yeah. Yes.
So the GP has the time.
Yes.
That's going to just help things to start off with. So have a long appointment and maybe even tell the reception team you're interested to talk about mental health. So they're sort of putting you to a GP that's maybe got more interest in working with mental health clients.
Yeah.
From there, if you've already done a little bit of research about what OCD is and how the areas that it connects for you, then you can present that to your GP. If you're not comfortable going into the specifics of what you're thinking, maybe you're afraid, that's okay. You can just talk about there being, say, repetitive, intrusive, uncomfortable thoughts that you can't get out of your mind. They're the opposite of who you are. It's not things you want to do, but it's distressing and overwhelming you, and you think you might have OCD and you'd be interested to have further treatment for OCD. So you can sort of help lay it out for them. They'll do their own differential diagnosis, but that will sort of at least steer them in the direction of looking at OCD as important.
Yeah.
The other thing I would suggest to people, particularly if you're a bit uncertain about disclosing stuff to other people yet, is to try the online treatment options through This Way Up, Mental Health Online and MindSpot. Those three organisations have amazing evidence-based free treatment for Australians for OCD. Their outcomes are really good, they're published and they're accessible. Wow. And it's a great way, and it's both a really good introduction to learning about OCD and treatment for OCD. And some of them there's the option of like a therapist to support you as you're doing it.
Amazing.
I think there's one for kids called OCD Not Me.
Yes.
And that's kind of a similar
Absolutely,
idea.
yeah.
And we'll put all
parents can
these
be
in
part
the
of-
the parents are involved. We'll put these in the show notes definitely,
Yeah.
because I think that's a really good point about kind of even dipping your toe in.
Yeah.
And not actually having to physically speak to someone about it if you're really worried about that.
It can be a great way to sort of learn more about your experience, learn that there's, start the treatment. And sometimes for some people that's enough. I've worked on the research trials on some of these things and I can see the amazing impacts that this has had for people.
Yeah.
Some people might want it a little bit more tailored to their specific situation, and that's where referral to a psychologist or psychiatrist might be warranted.
Yeah, and there's also the reality that, seeing a therapist and being able to get a mental health plan is a privilege within itself. So for people who can't afford treatment or to see an ongoing therapist, those type of resources would be life-changing, I assume.
Absolutely, yeah. And I think good to mention the mental health care plan there, Angie, and what you were saying, Claire, about maybe organising a longer appointment, because sometimes that can then be talked about with your GP before seeing a clinician as well, and making that a little bit more affordable for a while.
Yes, absolutely.
Yeah. So, Claire, I just want to ask you a little bit about OCD and anxiety, because obviously they can overlap. I mean, I know certainly for myself, I can't picture having OCD without having anxiety.
Yes.
But I was diagnosed as having just anxiety for so long.
Yeah.
Can you just maybe talk about some of the differences between OCD and anxiety?
Sure. So first of all, anxiety in and of itself isn't a disorder. It's an emotional experience. A normal human emotional experience might not be very comfortable, but it's part of being human. But I think what you're talking about is, say, generalised anxiety disorder, which is a disorder sort of characterised by worries. And the phenomena of worries and obsessions are quite similar. So they're both unwanted, negative, intrusive things that enter into your head and are difficult to control. So that's where, at face level, it can look quite similar, and where often there can be misdiagnosis as a result of it. There are some key differences, however. Worries tend to be more general, more vague, and more relevant to everyday life things: work, finances, relationships. And it tends to be more pervasive throughout the day because we're thinking about those things throughout the day all the time. OCD, the obsessions tend to be quite specific and quite nasty, quite negative, worst case possible scenario. But there's a part of the person that's like, oh, I don't know that that's even possible. So there's this awareness of the irrationality of it, which only just makes you feel a little bit more distrustful of your sense of self.
Yeah.
Which brings us to the main difference between the two is ego dystonicity or ego dystonic, you're going to have to do something about it. Ego syntonic.
Yeah.
So the main difference between the two is the content and the degree to which it aligns with or is in contrast to your sense of self. So in OCD, the obsessions are in contrast to who you are and what you care about. It's completely opposite to your sense of self. So someone who's really caring and loving and cares a lot about their family, having unwanted thoughts of harming family members, for instance. So it's against anything you'd really want to do or want to happen. Whereas in a worry, it's in line with your sense of self. So someone who's really caring and they're really worried about a family member who's ill and in hospital.
Yeah.
So their care and attention there is like it's more connected to real life everyday events as opposed to an obsession. It's more connected to something you would never want to do in the first place.
Yeah. That is so interesting. Claire, what's a good answer for someone like Penny and I to say to people? Because I think we both often get, which I completely understand and appreciate, maybe friends or even people, online being like, I can think about something for a few weeks and like it worries me and what have you, and it makes me quite anxious. But yeah, how do I know if it's OCD or not? Like, is it just anxiety? And I don't know, to be honest, if I'm saying the right thing, because I say, well, for me, the things and the intrusions aren't actually happening, and they are so paralysing to me because it's the last thing that I want to think about and want to happen. And also they are followed by rituals and compulsions.
That's right.
Which only exacerbate the worries.
Unfortunately,
they do not help. And, you know, because recently, to kind of put as an example, someone was like, oh, I was really worried about my health. And the results came back and now I feel fine, like everything's fine. And I'm like, totally. And I'm like, myself in that situation would be like, they've sent me the wrong, you know, they've sent me the wrong scan. When they say fine, like, is it fine? Like when they say average, like, am I actually on the higher or am I on the lower? And like, actually, sorry, I'm going to go back to the doctor because I think they got the wrong name altogether. I need to make sure.
I distrust.
I distrust this information. I'm not sure that I can trust what I'm seeing, what I'm hearing, what's been told.
Absolutely.
So I think one of the ways I understand OCD as being the disorder of doubt.
Yes.
So there's you doubt your senses. Can I trust what I saw properly? Can I trust that my hands actually are clean enough? You doubt your memory. Like, did I do that right? Did I actually do that? I'm not sure. You doubt your reality. Like, is this a problem? Did that happen? So
You doubt the doubt.
You doubt the doubt, right?
Yeah.
And you end up doubting your sense of self, your very essence of who you are as a human starts to get whittled down by OCD, whereas nothing is sure. Even if you do get to do the compulsion or you get the negative blood test that says everything's okay, rather than just experiencing relief to be able to go, okay, or maybe you will for temporarily, but then doubt comes back and goes, but can I trust this?
Yeah.
Maybe the doctor wasn't working. Well, it wasn't his best that day, maybe, and the doubt train
wasn't my blood. Like
runs on.
Nothing stops.
There's I often tell clients there's no satiation here. There is nothing that people can say. There's nothing you can do that's ever going to feel like you're never going to feel satisfied.
It's like a itch you can't scratch.
It's never going to be able to be scratched.
Yeah.
So that's why in treatment we're like, let's stop trying to scratch it.
Let it.
Yeah.
But we can understand, like, there's that need to. That's the compulsion, right? There's this need to try and do something to make this uncomfortable sensation go away.
Yeah.
Oh. Yeah, it's pretty tiring. I mean, and it is. It's so tiring, and this is the thing. Like, it's so exhausting and pervasive.
Yes, and all-consuming.
And all-consuming.
Yeah.
I know for me, getting a diagnosis was like this weight off me. Like, I really felt lighter because of it, and I felt like it was something that was kind of happening to me. I wasn't inherently bad. I think that was kind of like a initial feeling I had. Do you find generally that's the experience for people getting diagnosed, or is it kind of just, it just depends on the person?
No, I think that's common. I think relief is the most common. There's something so powerful of having someone accurately understand your experience and be able to sit with you and go, it's okay, I know what this is and I know what we can do about it. And having someone hear you and feel you and see you in that way is so, so powerful. Because don't forget, the obsessions have you thinking like there's something wrong with you, that you're crazy in some way. So for someone to be able to say, like, the first session, I'm often, one of the things part of my first session is letting them know this is common, everyone has unwanted intrusions. It's usually so surprising to people to consider that. Yeah. So it's massive relief. Yeah. Sometimes with that can also come loss, though.
Yes.
Feeling of grief.
Yeah. Right? Yeah. So the grief over the years lost. Yeah. But hopefully we can then turn it towards hope. In having a diagnosis, you then all of a sudden the door opens to being able to access, okay, now that we know that this is the diagnosis, what treatment modalities are going to be most suitable for this situation? And I know, Penny, you've had groups before, so how can I meet others in similar situations?
Yes.
That power in connecting with like-minded others like you two have is so meaningful, right? So that's where a diagnosis can really sort of aid that sense of connection again.
Totally.
There's a kind of roadmap. There's a way out, and even though the way out isn't easy necessarily, you know, like you said, there's hope. Yeah, absolutely.
Yeah, and just also that, as we often talk about, Penny, that visibility of what OCD is for some people. So I think, you know, definitely one of the reasons why I didn't think I had OCD is because everything that I'd been exposed to, which was OCD, was something I could not relate to.
Yeah.
So, you know, washing hands, matching symmetry, you know, whatever it might be. And so I was like, that's all I've ever seen OCD to be. And I'm not saying that that's not a very real thing for people, but because of the lack of visibility and awareness of what it actually is, I was like, I must be really sick, or I must be really crazy because that's not me. And then, but through visibility and hearing Penny's story was like literally life-saving for me, and then because of that, getting onto the right help. And I guess why I bring this up, Claire, and I actually don't know if we can speak about this, but, you know, what are some themes out there that you see a lot in your office space that completely derail the stereotypical or mainstream representation of OCD?
So I think most people, when they think of OCD, are probably thinking of so the way OCD is generally subtyped is according to the compulsion side of things.
Yes.
So what people, and the compulsions that are behavioural, so the compulsions that we can see,
visible,
are more obvious, right?
Yeah.
And so they're the most common presentations that we might see in sort of public, in the media or, you know, movies, that sort of thing. So washing, you know, compulsively washing your hands for fear of contamination, or repeatedly checking or ordering things. I think more hidden, but no less common, is compulsions that are mental compulsions. So these are compulsions that are not observable. You know, I could be having one right now, no one would really know. Maybe if I was a bit distracted, you might consider it, but no one can really tell just by looking at someone. And what that person might be doing is basically anything, any form of mental response designed to decrease their anxiety or reduce the chances of something negative happening.
Yeah.
So commonly we might see people replacing the negative thoughts they have with a safe thought or with a nice thought, or counting to a safe number, mental checking. So checking doesn't have to be physically checking things. It can also just be mental checking, like, did I lock the front door? Then I did this and then I did that. No, did I? So that mental checking is a massive one that can take a lot of time and energy.
Yes.
But it's not observable to others.
Yeah.
Sorry, you were
I was just, do you think, Claire, like, there are certain things that a loved one could look out for in, you know, their partner or their kid or whatever, if they have the feeling they might have OCD, but they're not necessarily doing these mental things? Are there typical behaviours that you might see? Like, I'm just thinking, for example, like as a kid, I would spend a lot of time like in the bathroom, removing myself from whatever situation it is so that I could perform these mental compulsions. Are there certain things that people could look out for that might kind of give it away a little bit, or is that a difficult one?
Yeah, I mean, it's quite broad. It would depend on the individual, because just as like OCD can present quite differently between two people with OCD, but within the same person with OCD might present differently from week to week.
Yeah.
So the behaviours don't necessarily tell you so much. So for instance, I'll have a client that has contamination around food, and so one week they're restricting their food intake, and then the next week the contamination is sort of shifted towards the construction site next door and asbestos, and so they're not leaving their room. So if you're just looking at the behaviour, we're looking at restrictive eating and agoraphobia, like difficulty leaving a safe space. That doesn't really tell you very much, right? And you could understand why you sort of look at that behaviour and think, oh, something's up but not sure what.
Yeah.
So generally speaking, I think what I encourage parents or carers or clinicians to do is to ask, what do you fear is going to happen if you couldn't stay in the bathroom and you were asked to come out early, or you had to eat this piece of toast that you don't want to eat? What are you afraid is going to happen? So that gives us a little bit of an indication. Are they afraid of putting on weight, or are they afraid of contamination?
Yeah.
So because the behaviour doesn't really give us much of a clue, it's the motivation behind it we need to uncover, and that only really comes from the individual sharing their experience.
Yeah.
Now, one of the difficulties that can be is that we can't force people to talk, right? And it's notoriously difficult with children and adolescents, and even people that are sort of quite ashamed about their experience. So what I suggest is, rather than forcing people, because we can't make people talk, but create opportunities to show that you're interested, that you're available to hear their experience, and that you care. That you feel that you're going to be able to handle it. So whatever it is, we'll work this out together.
Yeah, you're safe with me.
You're safe with me. And if I don't know what to do, that's okay. We'll figure it out.
Yeah.
You don't have to know exactly what to do. It's more about that sense that whatever it is isn't going to overwhelm you.
Yeah.
And you can help the person through.
Yeah.
So just creating opportunities to be able to talk is probably the best opportunity.
That's beautiful.
Yeah.
I really like that.
And before, Claire, you were saying this is another one that Penny and I hear a lot, like, oh yeah, I'm a bit OCD.
I'm so OCD.
I'm sorry, OCD, like everything matches, or what have you. Would you be able to explain to our listeners the difference between OCD and personality disorder?
OCPD?
OCPD.
Okay, so I think so when people are saying I'm so OCD, I think they're mostly referring to the fact that everyone has unwanted intrusions, and some of us do like a little bit of order.
Yeah.
But for the majority of the population can dismiss them, don't engage with them. Exactly. Get on with their day. Doesn't really have to impact their quality of life. Whereas for OCD, the disorder, it's disabling. OCPD is another type of disorder. So it's obsessive compulsive personality disorder.
Yeah.
And by definition, a personality disorder is more pervasive. So it's around all areas of life. Where so both OCD and OCPD might have a want for perfectionism, for control, a need for order. There might be rituals around order with some subtypes of OCD. But the difference is that in OCPD, it would be in all areas of life, and in OCD, it would be specific to an obsession about something. So that need for order and control is around a particular obsession.
Yeah.
And I guess OCD tends to be more fear-based, and there's a lot of anxiety around what's going on, whereas in OCPD, there's less anxiety. There's more of like, no, that's just the way it should be done. So it's more about an idea of that things being done the right way, versus in OCD, there's this anxiety about it not being the right way.
Yeah.
So probably, I mean, I imagine shame doesn't show up as much for OCPD because it's not. So it's you're like, this is the way it should be. This is how I'm going to do it because this is the right way. Yeah. Yeah, that makes sense.
What comes to me, Claire, is a Kardashian episode.
Yes. Oh my God, the Kardashians do it all the time.
All the time. And apparently it's called Chloe OCD.
Chloe-CD.
Because it's Chloe. And there's like this example where they put, all this fruit.
Yes.
But they change like one to a different colour or whatever.
Yes.
And she's just like standing there and she's like, I feel uncomfortable, but I'm fine. Yeah. Like, would that be an example of OCPD? Like a very simple example of kind of being like she prefers and likes.
As someone that watches the Kardashians
yes.
and loves my reality TV,
yes.
I think there is more anxiety to that specific situation.
Yeah, sure.
But generally speaking, it's more of a like discomfort. I mean, anxiety can manifest as discomfort.
Yeah.
So, it's hard to I wouldn't be able to diagnose based on what's on telly.
Of course. But would a personality disorder, OCPD, be more like...
It's more frustration, I would say.
Yeah.
It's like, no, this is the right way.
Yeah.
Versus that sort of sense of discomfort, like, oh, it just feels wrong. Like there's anxiety about it. Maybe the anxiety might be about something bad happening if it's not ordered a particular way, or there's this real discomfort of the feeling that comes with them and that meaning something. So that, they feel like it's out of place.
Yeah.
And thereby they can feel internally a sense of unease.
Don't feel right.
No, it doesn't feel right.
Yeah.
And then that sense of unease is then what spurs on this sort of anxious response.
But it's not like, oh, the book's not in the right place, so that means I'm going to kill my sister.
No. No, well, no, not OCPD, no.
Yeah. Oh, no, totally aware of what OCD does. But, yeah, like, could that be a way to distinguish it? Like,
It's.
oh, Angie, just shut up.
Yeah, I mean, I think you can just try and understand to what extent there's anxiety surrounding this, and is it pervasive?
Yeah.
Across all areas.
Yes.
And this is a general way of doing, or is it quite specific to this particular thing?
Yeah.
And there's an obsession attached to it in some way. Something bad might happen if they don't do it, or the distress of it being in the wrong place is too high to handle.
Yeah.
Yeah, and it can present together as well, can't it? Like you can have OCPD and OCD.
I mean, yes. And I guess back to the generalised anxiety disorder, there's high overlap between the two conditions in terms of comorbidity. I would say, if not the majority of my clients, because I tend to see clients, quite severe end, the majority of them have generalised anxiety disorder as well,
Totally.
I would say. So, we're sort of trying to combine treatment modalities to create something meaningful.
Yeah. I often come across parents who think their kids might have OCD, and we're not going to go into, like real specifics around kids and OCD, but I see this kind of real hesitancy with parents to diagnose their kids with OCD, as in they can't diagnose them, but to take them to someone who might diagnose them for fear of labelling or, whatever it might be. What would you generally say to parents or to someone who has a loved one with OCD around that fear of being labelled? Do you think the
stigma?
Stigma. But do you think the positives outweigh?
Yeah,
the
I mean,
negatives?
I think ultimately, regardless of diagnosis, information is helpful. Yeah. So learning more about yourself, your vulnerable parts, your strengths is always going to be helpful, right? So generally speaking, I see quite a lot of parents sort of working with them on how they can support their children, right? So maybe I'm not working with the child directly, I'm working with the parent about what they can do. And these are parents that are, have been able to seek help, but where they have, sometimes it has taken a little bit of time for them to be able to get into that position, to be able to go, actually, maybe I'm going to do something about it. Because, as you say, there might be fear about being labelled or what this can mean. But generally speaking, I think information is power, and having more of an understanding can provide opportunities of what we can do about it, which elements here are in our control and we can make some changes with, and which elements here are part of our house experience or home experience, and that's something we need to learn and accommodate to. So, I just think information is power in this situation.
Just hearing you say that in your question, Penny, I often cry to Andrea because I'm like, what I would have given what I would give to go back and get diagnosed at a younger age. And of course that's just my experience, but the grief of the decades lost is I feel like I'd be a totally different human being in a way if I was diagnosed young. But that's my own therapy session.
But also, I guess it's important to note though that, like, along those lines, is that the very things that make someone vulnerable from their OCDs are going to also be their strengths. So therapy or treatment isn't about getting rid of this part of yourself.
Yeah.
It's more about learning more about who you are and how you can work with that.
Yes.
And for you to be the people that you are today, like, you've got strengths that have come out of this. That's what I try and look for with my clients, is try and see where the strengths are and see how they have grown through this experience as well. So, I can completely appreciate that early diagnosis is a real opportunity to be able to work that out with someone and to help their sense of self feel like that there's something that can be done here.
Yeah.
Do you think, Claire, there'll ever be like kind of national guidelines around treating OCD?
I mean, we have, so clinicians, might look at, say, UK guidelines or US guidelines.
So they do have national guidelines around it. Other countries do.
Yeah, absolutely. So the National Institute of Clinical Excellence in the UK has clinical guidelines for OCD, and that's where, the research about first-line treatment is ERP, for instance. So, clinicians in Australia can access those guidelines or the ones in the US. And in Australia, we might have guidelines, say, with the Australian Psychological Society. There's, guidelines there about as well. I think, though, it would be good to see a more coordinated approach. We know that OCD is one of the leading disorders of disability. The World Health Organization has recognised previously OCD as being one of the top 10 disorders of disability in the world, aligned with like diabetes and cardiovascular disease. So huge, massive impact both on the individual and on society. And there are, there's clinicians and researchers that are advocating, and for things like more sessions. So at the moment, a mental health care plan enables someone to be able to access up to 10 sessions, Medicare rebatable sessions, but clinical guidelines suggest actually people probably need 20 and for more, at minimum 20, and for more severe ends might mean 30 or 40 sessions.
I've almost run out of my 10.
Yeah. Absolutely.
Yeah.
So, there is a need for a more coordinated approach and to sort of see the impact that OCD has on people in society.
Yeah.
As a clinician, Claire, speaking to the audience, what would you want to tell people with OCD?
You are not your thoughts.
Yeah.
You are not crazy, that everyone has these uncomfortable... trust me when I say I have every single unwanted intrusion in the sun. You name it, I've had it. The only difference with me compared to someone with OCD is that I'm able to go, oh, that's random, okay, let that go for the day. That's a bit bizarre. Oh, that's a bit disgusting. I'm able to let it go. That's the only difference between me and someone with OCD, whereas someone with OCD has that thought and thinks, shit, what does this mean? I need to do something about this. I need to control this. I need to get rid of this. And sort of this this engagement with the obsession comes.
Yeah.
So I would just want to let people know that these thoughts do not define who you are. And in fact, the fact that you are distressed by the occurrence of the thoughts tell us diagnostically that it's the complete opposite to who you are. You're not someone that wants to harm others, for instance. The fact that it distresses you tells us that.
Yeah.
And so as clinicians, we know that that's not something that you're wanting to do. It's not a wanted thought, it's an unwanted thought.
Yeah, that's really powerful. Just, I guess, summing up and going back to that really long, not for everyone, but that kind of average time of 9 years, or whatever the research shows, from onset of symptoms to diagnosis. I guess to change that, there's so many things that have to happen, aren't there? Like you've got, starting with kids, it might be missed
screening with
missed
children.
Screening and missed, like you said, maybe not asking the questions that need to be asked. Generally, in the media, the representation of OCD. I mean, it is changing slowly, but that also needs to change. You need to have GPs who are kind of looking for it as well and have knowledge, and then obviously clinicians. So it's like a lot of different factors that need to kind of change and grow to make any kind of difference. Are you kind of hopeful, Claire, that things are slowly changing on all fronts?
Huge. I mean, just in the, however many years I've been working in this space, I've seen the mental health literacy of the general public has increased. So I never used to get people saying I have OCD. I used to just have people coming, I'm having these thoughts, and then I would diagnose them as OCD. So I feel like, things like podcasts, websites, books, all of those sorts of things, all that sort of public literacy is really important because that's where we can get accurate and accessible information out there. And from that, people might be able to self-advocate for this is something that I want to have some more support in. So I think that, there's already momentum happening there. I've also seen improvements in therapists being interested to work in this space. So, I've loved working in this space. I'm constantly trying to get other psychologists to work in this space with me. And there's previously been a bit more hesitancy, but I feel like that's changing as well. I'm getting more and more people contacting me going, I'm ready, let me get some supervision in this area. So I feel like there's definitely some movement happening there. Yeah. And I think that's because they're also having clients present to them going, I think I have OCD, can you help me? So that also shows where that sort of public knowledge is so powerful.
Yeah, that's really hopeful to hear.
Yeah.
And another thing I've noticed that's improved is so when it comes to, say, perinatal mental health, so huge. Anxiety and depression, I've noticed that they've started to include screening for OCD.
Oh, yes.
So, maybe it might not, I'm not sure if it's with the mental health, what are they called? Maternal health nurses side of things. But I know in the training, there's, I've seen that there's training now about asking those questions because we know that it's common for people that have a baby, particularly first-time parents, to have unwanted thoughts of harming their child. That's a normal experience of being a parent, to be honest, but
that can be debilitating.
It can be debilitating. Or you can have it like me and just go, okay, well, that's just random. That's not anything I need to attach to. Or most people are actually very, very vulnerable in that time. They've just had a child. They're already very tired and not sleeping and they're vulnerable. So, it's a very vulnerable spot. So, I'm glad to see that sort of there's much more of a focused effort there in clinicians that work in perinatal mental health.
So good to hear.
Yeah. Yeah.
Well, Claire, thank you so much.
This has been great.
For being with us today.
Yeah, thank you.
I've learnt a lot.
So much to say. It's amazing. It's just the never-ending barrel of OCD. Yeah. Thank you so much. You've
Not at all. Not at all.
Fascinating.
I'm so excited in this space. I think it's, and I'm so excited that you guys have put this out there. I think it's a valuable resource, and I've already seen the impacts that your book, for instance, has. And some of the podcasts I think that you've done, that people, that's how people first time I listened to this podcast and that's where I first learned about this. So
that was
really
me.
Powerful. Yeah. It's really meaningful.
Thanks, Claire.
Yeah,
Thank you, Claire.
If this episode has caused any distress and you need to talk to someone, please call Lifeline on 131114 or see your local GP.